Okay, this is sort of a lecture which probably should be given earlier in the year because it is extremely important since this is when we admit kids. This is likely why they're going to be admitted. There's kids with IBD, and in this case, we're going to limit the discussion to acute severe ulcerative colitis. This is a definitive term. It's not an opinion. And so we're going to go over everything I think you need to know. And if there's something that you need to know that I haven't talked about, I'm sure Dr. Levine will join in. So so first and foremost, ASC, I'll abbreviate it, easier to do it that way. ASC is a life-threatening condition. It has a high rate of rapid deterioration requiring colectomy. It's important to know that up to 40% of children and adolescents with UC will experience at least one episode of acute severe colitis during their disease course, and adults, 18 to 25% of adult ulcerative colitis during a 10-year follow-up will have an episode of acute severe colitis. So it's a common problem, more common actually in pediatrics than it is in the adult instance, probably because the younger you are, the more severe your UC tends to be. So is this a case of acute severe colitis? Would you say yes, no, or I don't know? Give me an answer. Anyone?
The hint is that it's outside the body.
Well, if it's outside the body, it likely is. But the important thing to note is that acute severe colitis is not a visual diagnosis. It is not an endoscopic diagnosis. It's an opinion. So let's take this excised colon, obviously, and look at this. Can you tell if this patient has acute severe colitis? First of all, how can you tell this is ulcerative colitis and not Crohn's disease? Fellows only can answer the question. Silence. Silence. Okay.
Is it the fact that it's not full thickness?
It's not full thickness. If you look at this, you can see there's intense inflammation of the mucosa, but you can almost draw a line between the mucosa and the submucosa that it stops. Now, can it be transmural? Of course it can. But this is very typical of an ulcerative colitis biopsy with intense inflammation. Now, can you tell from this biopsy whether this patient has acute severe colitis? Yay or nay? Or I don't know. Okay, so I'm going to take just a few seconds to note the fact that this is something you should know from your experience. You can't tell. All you can tell is that this is consistent with ulcerative colitis. Pediatric acute severe colitis is a clinical diagnosis. It is not a laboratory diagnosis. It is not an endoscopic diagnosis. In the old days, however, when Dr. Rabinowitz and I were young pediatric gastroenterologists, what we used to define pediatric ASC was something called the Grand criteria, named after our friend Richard Grand up in Boston. And it comprised of any three of either bloody stools greater or equal to 5 times a day, tachycardia, fever, anemia, and hypoalbuminemia. And we'll see later that hypoalbuminemia becomes a very important predictor of severity. However, in 2025, we take all of these laboratory values and all of these clinical assessments, and we basically use something called the PUCI score. And the PUCI score is something you should teach all your residents to know about, because it's something that's very simple to obtain on the basis of just speaking to the patient. And we'll talk later about the gradation of PUCI, but patients with UC in remission, and it's an exclusively ulcerative colitis scoring system. If you're in remission, your PUCI is less than 10, mild 10 to 34, moderate 35 to 64, and severe greater or equal to 65. And the PUCI is shown here, and it's an assessment of abdominal pain, rectal bleeding, stool consistency, number of stools, the presence or absence of nocturnal stooling, and activity level. Note there are no laboratory determinations. This is purely on the basis of history. When you admit a patient with ulcerative colitis, residents on the floor should be calculating a PUCI every single day. It takes a couple of minutes to do it and is the most important measure of severity in pediatric UC. If we look at patients who present with ASC, what is alarming about them is that a very high percentage turn out to be steroid refractory. And that rate has been reported as high as 34% in children and 29% in adults. And the 1-year colectomy rate in patients with steroid refractory and ASC was 61% in children and 50% in adults. These are older studies. And again, this is largely in the pre-biologic era. So when you see a patient with ulcerative colitis who comes into the office, the decision is always, do we admit them or do we not admit them? In general, we follow the PUCI. Your decision to admit for more intensive therapy should be based, at least one of the major determinants, should be guided by your PUCI score. If it's greater than or equal to 65, that's severe disease. That is a no-brainer for admission. If it's 40 to 65, that has to be judged on an individual basis, based on what is the home situation, what's your experience with the patient, what medications are the patient on. Maybe this is a patient who's come down off steroids and is just on an aminosalicylate. That's going to be a lot different than a patient who comes in on a high dose of steroids with the PUCI remaining at this moderately severe level. So again, this is based on your individual assessment of the patients. But in general, anyone with a PUCI 40 and above could be considered a candidate for hospitalization. The diagnostic evaluation should be initially based upon whether or not you're familiar with the patient and whether there is a previous diagnosis of UC, because a significant percentage of patients with ulcerative colitis will present with ASC as their presentation. Careful history, you have to do a complete stool workup, and you have to find some way to evaluate the small bowel, because at this point, there's no way of knowing whether this indeed is ulcerative colitis, though it may be phenotypically like UC, or whether or not this is Crohn's disease. And when you have this initial presentation of ASC, you have to include infection, medication-induced diarrhea. Now, again, we know that medication-induced diarrhea will largely be antibiotics in this case. 5-ASA has been associated with medication-induced diarrhea. But again, if this is the initial presentation, the patient is unlikely to be on an aminosalicylate. And then you have to use a daily evaluation of the severity of the disease. Infection in UC is a significant problem and has to be addressed in any patient who presents with increased severity of their clinical status. The most important, of course, would be to rule out Clostridium difficile. 4 to 5 samples should be taken, and they should be screened before excluding infection. There's a low sensitivity of ELISA for toxins A and B. It's a 50% with 1 sample, but it does increase to 92% with 4 samples. The CDC guidelines suggest that ELISA for toxins A and B, again, have a high specificity, but a low sensitivity unless multiple samples are obtained. Evaluating for glutamate dehydrogenase antigen, again, has a high sensitivity and low specificity, but the PCR for toxic A and B genes has both a high sensitivity and high specificity, and in virtually all cases should be your go-to diagnostic test for C. difficile. Remember that if one does a sigmoidoscopy on these patients, you're generally not going to see pseudomembranes. Pseudomembranes are commonly absent in inflammatory bowel disease. Indeed, they're commonly absent in the pediatric age group as well, even with the infection. Other pathogens must be considered, including those that have rectal sparing, such as Campylobacter, Shigella, Salmonella, Yersinia, and especially Entamoeba histolytica, which tends to concentrate its damage on the right side of the colon. If one has rectal involvement and one is considering an infection in UC, then cytomegalovirus becomes your prime candidate. When one diagnoses C. difficile in acute severe colitis, obviously oral vancomycin for a 10-day course is a first-line choice. I can remember going in onto the floor at some point years ago where someone suspected C. difficile infection and the patient was on IV vancomycin, which does nothing. So remember that it's oral therapy that is required. There is no clear evidence in a patient with UC who has the infection to reduce steroids or immunomodulator doses in the presence of this infection. There is, however, data that show that adults on immunosuppressive immunomodulators with C. difficile appear to have a worse outcome, but that has not been evidenced in the pediatric age group. Remember that CMV infection implies evidence in the blood of a CMV colonization, but only positive CMV in GI tissues by histopathology, what we term CMV disease, not in the blood, CMV infection, is clinically meaningful. Only children with steroid resistance should undergo a sigmoidoscopy for biopsy. In a known patient with UC who comes in with an exacerbation, again, this is independent of the initial presentation with a patient without a previous history of UC. But with a previous history of UC, only children who are steroid resistant should undergo a sigmoidoscopy for biopsy. And immunohistochemical stains are more sensitive than H&E. And of course, you want to do PCR on biopsy tissue. Remember, antiviral treatment should be initiated along with an infectious disease consultation when CMV disease is identified.
May I add something, Dr. Schwarz?
Of course.
Just for the fellows, that the way that we have done it, and this was several years ago, so of course it would need to be confirmed, is that this is a very important point, prior to the colonoscopy, you need to have a discussion with the pathology resident who's on call. That will be able to coordinate getting the PCR done on the tissue. Previously, it was shipped out. I don't think that they do that here, but certainly one needs to have that discussion if you're thinking along this line before you do the colonoscopy to increase the likelihood of having a successful diagnostic procedure.
Correct. Now, remember, CMV infection is defined as CMV evidence in a blood test, not in tissue. CMV infection is common in patients on steroids and is associated with a high rate of steroid resistance. Adults with moderate to severe UC have frequent CMV infection during steroid therapy, but their UC disease course appears to be independent of CMV infection in the absence of CMV disease documented on biopsy. So how do we monitor disease activity? We use clinical variables, frequent vital signs. Heart rate and temperature predict response to steroids in adults, but not in children. In children, it's the daily PUCI scoring, the number of stools, the nocturnal stools, the amount of blood reflect disease severity. There is a limitation. When one gets above 65, and certainly even higher, above 85, then the numbers sort of don't mean anything anymore. Anything really above 65 should be considered to be severe. If it's 75 or 80, that's not to say that's more severe than above 65. So really, your 65 is your ceiling level, and anything above that, that's just severe disease. Laboratory markers. Well, CRP, cedrate, and albumin have some predictive role for assessing severity. We'll talk more about that later. Electrolytes have no predictive role, but they are part of the definition of toxic megacolon, and we'll go over that later in the lecture. If we go to calcineurin inhibitors, of course, and again, we'll discuss that, then you want to monitor magnesium, creatinine, and cholesterol to minimize toxicity. What about fecal biomarkers? We talk about fecal calprotectin, lactoferrin. They have very low responsiveness compared to clinical monitoring and have no role in monitoring disease progress of ASC. What about endoscopic examination? While the degree of inflammation of the sigmoid colon correlated with treatment outcome in previous adult studies, there's no similar data in children. There is no data to suggest that endoscopic appearance adds to the predictive value of the simple clinical variables that are obtained on the PUCI score. Sigmoidoscopic appearance, therefore, does not improve the validity of the PUCI score. Sigmoidoscopy should only be performed when the underlying diagnosis is unclear, to identify complications such as CMV colitis, and never do a full colonoscopy. We are not cowboys. This is not be the hero and see how far you can get. In patients with ASC, a full colonoscopy is too risky as it can precipitate toxic megacolon or even frank perforation. So do not do a full colonoscopy. What about the treatment options? Well, when I first made this slide, it was 2014. Now it's 2025. Maybe I made this slide before 2014. Anyway, we have two classes of drugs that are used for induction and drugs that are used for maintenance. In 2014, for induction, we had aminosalicylates, corticosteroids, infliximab was really our only anti-TNF inhibitor, and we had calcineurin inhibitors. Today, we have the same agents. The only addition is that we have a wider array of anti-TNF agents. The last two, adalimumab and golimumab, however, are not generally used as rescue therapy in UC anymore, or are not generally used as rescue therapy at all in ASC. It's still infliximab. And for maintenance, again, back in 2014, aminosalicylates, thiopurines, which we tend not to use anymore, and infliximab. In 2025, we have the same drugs. We have other TNF agents that were shown up above. And we have two new drugs that have been developed, and I'll just have more to say about them later. Vedolizumab, which is an anti-integrin a blocker, monoclonal antibody, to prevent white cell migration to inflamed tissue, and tofacitinib, which is the newest drug on the block, which is the new class of what we term JAK-STAT kinase inhibitors. And again, we'll go over tofacitinib in greater detail later in the talk.
Can I say one word here?
More than one word.
Great. You can use tofacitinib as a rescue agent for induction as well if infliximab doesn't work and the patient is very resistant to colectomy. It has a pretty fast onset of action between 3 and 5 days, so it can be used for induction. The problem we have at downstate is that we don't have it on formulary.
So, Dr. Levine, I will tell you something right now, and you have to promise me, and everyone has to promise me. Well, this is recorded, so anyway. I'm not going to have. If it wasn't recorded, I'll say more about tofacitinib offline at the close of the lecture.
Sounds good.
It informs directly in what you were just talking about. Its use as rescue therapy, and why I didn't put it there at this point. But again, it's not it's available on study pretty much in children right now. Okay, first line therapy for ASC. IV methylprednisolone, 1 to 1.5 milligrams per kilogram per day, with a maximum of 40 to 60 milligrams per day. 71% achieved the expected response rate. Methylprednisolone should be preferred over hydrocortisone because it has fewer mineralocorticoid effects, which is extremely important as these patients are likely to be on steroids for the long haul. In terms of dose ranging, there are really no good trials conducted in children. In the hospital, methylprednisolone given once a day was as effective as continuous infusion. Prednisolone in ambulatory adult UC found that 60 milligrams daily was no more effective than 40 milligrams, but had greater toxicity. Although in kids, we do go up to 60 milligrams obviously in adolescent patients. 40 milligrams once a day is as effective as divided doses. Remember, the greatest way to have non-adherence to medication schedules is to give your patients medications they have to take multiple times a day. If you can take it once a day, there's a greater likelihood of compliance. So remember, once a day steroids is as effective as divided doses. And importantly, less than 50 milligrams a day appear to have no efficacy in the management of UC.
One other benefit of giving steroids in one dose is that if you give it in the morning, it does decrease the activation, and so patients do sleep a little bit better.
Right. Glucocorticoid, trying to measure bioactivity doesn't predict the response. The bioassay for total serum steroid activity does not predict the need for second-line therapy. We generally don't do glucocorticoid bioassay activity, but there's really no role for it. Antibiotics are not recommended in all children with ASC. Strongly consider them pending a stool C. diff, and a stool culture. If ASC is the disease at presentation, if C. diff is locally common in your catchment area, if antibiotics have recently been prescribed, or if based on other symptoms you suspect infection, and of course in the setting of toxic megacolon. But this is going to be a choice you make individually based on your own assessment of clinical status, as well as what the recent history of the patient has been.
I suspect we could also here insert a debate about the utility of quad antibiotic therapy as a third or fourth line rescue therapy.
Yeah.
Are you referring to, Dr. Schwarz, in that last slide, therapy for specifically C. diff or generalized therapy?
If pending stool C. diff, strongly consider if C. diff is rampant in your community and a patient presents, you should strongly consider treating them pending stool C. diff assessment. What about antibiotic therapy as a therapy for ASC? In adult studies, no difference in outcome with IV ciprofloxacin, metronidazole, or metronidazole and tobramycin as an adjunct to steroid therapy. IV antibiotics, again from adult data, should be used in ASC only if infection is suspected. I love things like this, only if it's suspected. On the basis of what? And that is really a case-by-case determination. There's no data on antibiotic usage in pediatric ASC as an adjunct, and there's no reason to diverge at this time from adult recommendations. Heparin. Why would one use heparin in children with inflammatory bowel disease? Well, there is data, including from our own group, to suggest that children with inflammatory bowel disease, Crohn's and UC, are at increased risk for thromboembolic events. We know that risk is also increased in adults with acute severe colitis and appears to be age dependent, but there's no evidence at this time to support prophylactic heparin therapy in children with ASC.
Despite there being no evidence, I will say that there are a couple of papers that came out recently that support using it anyway. And it's not heparin, it's low molecular weight heparin, so Lovenox or enoxaparin. The data is, as Dr. Schwarz points out, quite inconclusive, but there's also been no evidence showing that it causes harm.
There are a number of studies on enoxaparin, which I think is going to be the drug of choice.
Yeah.
For patients independent of diagnosis who have a line-in and are in an intensive care unit.
Yeah, the best evidence for prophylactic enoxaparin is in patients with indwelling central lines.
Right,
And
right.
even that data is small studies and it's not great, but
Right.
it does show some protective effect in those studies.
Absolutely. Thanks for that, Annie. 5-ASA, not much to say about it. Its role in ASC is not studied, but generally this is a maintenance drug. It's effective for induction only in patients with mild to moderate disease. It's likely to have little benefit when aggressive medical therapy is administered. Sometimes patients put on 5-ASA will actually have worsening diarrhea, but in general, this is not an ASC drug. Interrupting it, if the patient is on it, a known patient, interrupting a 5-ASA is recommended because there's no value of evidence during severe colitis. And if this is a 5-ASA naive patient, you want to delay the introduction of the drug until the patient is clearly in the recovery phase. Nutritional support. Well, there's really no evidence that parenteral nutrition is worthwhile in these patients unless surgery is imminent or they have toxic megacolon or they cannot tolerate an oral diet. But in general, as regular a diet as the patient can tolerate is recommended. There's no benefit of bowel rest in addition to steroids for ASC. But again, this is going to be an individual discussion on an individual patient.
And for patients who are having PO intolerance, remember that enteral feeding is always preferable to TPN, especially in these
Correct.
kids who are thrombotic setups. So drop an NG tube before you place a PICC line.
Correct. Sometimes it's easier to say we're going to put a line in you than putting in an NG tube. But Dr. Levine is spot on. Anything enterally is going to be preferable to anything parenterally for a wide number of reasons. Pain management. If a child has severe or escalating abdominal pain, that may be an indication to evaluate them for both perforation and or toxic megacolon. We know in our patients, some may have pain out of proportion with disease severity. That is a question that you have to try to answer based on your knowledge of the patient and their history, but can be a significant problem. In those cases, use of relaxation techniques, hot packs, or acetaminophen. I would try to avoid anything that suggests an opioid. As a matter of fact, there's a recent paper that just came out, recent study on tramadol that said that in patients with severe pain, not only didn't it do anything, but there's a much higher incidence of side effects, some of which could be severe. So opioids are not the way to go.
Fortunately, you sometimes have no choice because these patients are in very severe pain. And so we try to be as opioid sparing as possible.
Right.
In some centers, so morphine is your first choice if that's all you have, and you try to use small doses as infrequently as possible. Remembering that an opioid will decrease bowel motility and can increase the risk of toxic megacolon. In centers that have nalbuphine available, that's the drug of choice because it's a mixed kappa and mu, and it's a partial agonist for the mu receptors rather than a full antagonist. And so it has a ceiling on the respiratory depression effect.
So when you have a patient with severe pain, it's useful to get a pain management consult or a Dr. Levine consult. But this is something that, as pediatricians, we're not used to dealing it, to getting out. So, it helps to get help.
And the reason also that we avoid NSAIDs is that, if you'll recall, they help divert blood flow away from the intestine and gastric mucosa, and so it can paradoxically worsen bleeding.
Well, right here, an NSAID
Oh,
exposure
sorry.
will increase exacerbation without a dose effect relationship. NSAIDs also can cause mucosal ulceration, obviously. So we should try to stay away from them.
For the fellows, I'm so sorry, that when Dr. Schwarz says investigation for perforation and toxic megacolon, that specifically means an X-ray.
We'll talk about it. I'll get to that.
Okay, go ahead. Sorry, go ahead.
So monitoring the response to steroids, PUCI is superior to all adult indices. We've said that before, I'll say it again. When you place a patient on 40 to 60 milligrams of steroids, you measure their PUCI daily. If it's greater than 45 on day 3, prepare for second-line therapy. Greater than 65 on day 5, prompt initiation of second-line therapy. 35 to 65 on day 5, you can continue steroids for an additional 2 to 5 days before deciding on second-line therapy. And if it's less than 35 on day 5, this patient is unlikely to require second-line therapy. Now, again, these are but, general guidelines, and you have to individualize on a patient-to-patient basis. So if the PUCI is greater than 45 on day 3, remember that's moderate disease heading up to the severe range, discuss treatment options with the family, get a surgical consult, do TB screening in preparation for second-line therapy. You may want to do a sigmoidoscopy on the 3rd or 4th day to exclude infection and search for chronic changes in granulomatous inflammation. More than one patient billed as UC turned out to be something different. And CRP should be monitored, as very high values do have some predictive value, again, in adults and in children. Day 3 is your screening day. Screen for steroid failure. If it's greater than 45, that patient may be steroid resistant. If it's less than 45, that patient is likely to have a complete response. Day 5 is execution day. That's execution of therapy. And that gives you more specificity for second-line therapy. If the PUCI is greater than 70, then 100% of patients go on second-line therapy. If it's greater than 65, almost 100% go on second-line therapy. So again, anything 65 and above on day 5, you are going to start second-line therapy. Whenever planning rescue therapy, surgery must be seriously considered. And this is why you get the surgeon involved. And that's going to depend upon how well you know the patient, how many episodes have they had, how old is the patient, and whether surgery has been something you discussed previously as well. The second-line therapies, again, the first to come out of the gate were the calcineurin inhibitors, including cyclosporin and tacrolimus. And of course, now we tend to use infliximab. Vedolizumab, I talked about as an important UC drug. It is an anti-integrin monoclonal antibody, and it may be a first-line drug for steroid-dependent UC. The problem is there's a very slow onset of action, sometimes taking 2 to 3 months. So it really is not a useful drug for ASC. The other thing is that there are some studies, and they're very few in number and very few patients, would suggest that patients on vedolizumab may have increased surgical morbidity. So again, this is a drug which is largely a maintenance drug and really has no role in acute severe colitis. What about the calcineurin inhibitors versus infliximab? If the patient previously failed an adequate trial of thiopurines, and this is more for adults, or back in the old days when we used thiopurines a lot, then infliximab was preferred. Calcineurin inhibitors are short-term drugs. They're typically given for 3 to 4 months as a bridge to an immunomodulator, which historically was 6-mercaptopurine or azathioprine. And then in evaluating for second-line therapy, obviously, if the patient has hypomagnesemia, hypercholesterolemia, hyperglycemia, azotemia, hypertension, or CNS abnormalities, then infliximab is preferred.
We don't use tacrolimus that much for rescue therapy anymore just because it has so many toxicities and it's not a good long-term maintenance agent. But I have seen it work wonders. It has a if it's going to work, it's going to work quickly. You'll know within a few days. But just remember that it has to be bridged to somewhere.
We'll talk about the response rate to the calcineurin inhibitors versus infliximab, which is very interesting work. In terms of response rate to cyclosporin, there were 8 retrospective case series in children with 94 subjects. Only 39% avoided colectomy in the long term. And there was better long-term success rates if they were able to be bridged to an immunomodulator, such as azathioprine or perhaps methotrexate. Tacrolimus, 24 children, 3 small case series, 67% showed a good initial response, but only 22% sustained response in the long term. Infliximab, there are 6 case series in children, 126 patients. The pooled short-term response rate is 75%, long-term 64%. It decreased the short-term colectomy rate to 9% and the 1-year colectomy rate to 19%. Now, adult study, very interestingly, there have been an adult study, one clinical trial giving 1 dose of infliximab to 45 adults. There were 7 out of 24 in the infliximab group, 14 or 24 in the placebo group. And in this case, it really did nothing to change the long-term response.
Steve, are you going to talk about albumin carrying and
I will talk about
redosing?
Yeah, I will.
Okay, so I won't say that here.
Okay. So in terms of cyclosporin and infliximab, both drugs are well tolerated and have equivalent efficacy in inducing a short-term clinical response, mucosal healing, and decreased colectomy rates at 3 months. Cyclosporin was not more effective than infliximab in patients with ASC refractory to IV steroids, and treatment choice should be guided by physician and center experience, which is always the case. And here is the albumin data. This came out last year in the Journal of Crohn's and Colitis. This study looks at only children with acute severe colitis at initial presentation. Both y-axes are the percentage starting infliximab, and the x-axis is the time before they started time to infliximab therapy in terms of weeks. In children with ASC at initial presentation, boom, 50% within a week were on infliximab. And that number steadily rose so that by 78 weeks, a year and a half later, we had almost 80% on infliximab. Those are children with ASC at initial presentation. Again, looking at the same children with ASC at initial presentation, let's look at it in terms of their albumin level. If they were hypoalbuminemic to the level of less than 2.7, that's the black graph, you can see that 75% within a week were on infliximab, and by 78 weeks, almost 100%. If the albumin was 2.7 to 3.2, again, we have maybe 35% within a week, gradually rises. So about a year and a half, we have about 70%. And again, the same is for those with a albumin of greater than 3.2. By a year and a half, roughly 70% are on infliximab. So here, a really important value is hypoalbuminemia less than 2.7, because there's virtually 100% likelihood that these patients are eventually going to be on infliximab. Annie, you want to comment?
The other thing I want to point out about albumin and infliximab is that remember that infliximab is carried in the bloodstream by albumin, and that one of the things that we depend on for infliximab to work is having a steady level in the blood. So if patients have a low albumin level when you start them on infliximab, they are going to lose a lot of that drug. It is not going to stay in the bloodstream. It is not going to be effective. It is not going to get to where it needs to go. So if your patient has an albumin level of less than 3.0, when you are planning to start infliximab, you need to give them extra albumin infusion before you give them medication so that it sticks around.
Annie, what about the dose of infliximab?
The dose is also important for kids who are this sick. I don't start them at 5 mg per kilo. I start them at 10.
That's exactly what I was hoping you would say. Remember that you see, a simple way to look at it is that the inflamed tissue eats up the drug. And if you combine that with hypoalbuminemia, it's sort of like the two-hit hypothesis. You're in the worst possible scenario for positive response. So giving albumin and a higher dose of infliximab is where you really need to go in this situation.
And ideally, the steroids have had a few days to soak up some of the inflammation too, so that the infliximab has a better chance of maintaining a level after the first dose. But the other thing that sometimes you can do is instead of waiting 2 weeks to give the second dose, if you're not seeing a significant clinical response, you can give a second dose within 3 to 5 days.
Correct. And fellows, you have to do this in close concert with your attending, because nothing is better than clinical experience with these situations. So how do you determine the short-term success of second-line therapy? With calcineurin inhibitors, you'd like to see a PUCAI going down by 20 points within 5 to 7 days. And something that Dr. Levine alluded to is that the response to calcineurin inhibitors tends to be quite rapid. Now let's contrast with infliximab, where the short-term success is no worsening of the PUCAI at 7 days and an improvement of the PUCAI 20 points within 2 weeks after the first infusion. And that's, again, going to depend upon a lot of factors. How much drug have you given? What's the albumin? But again, these calcineurin inhibitors tend to work quicker. The downside, of course, is that they're short-term therapies, where once you start infliximab, you can continue it indefinitely. So let's look at one prospective multi-center study of outcomes and predictors of response. This is 128 eligible admissions. 37 or 29% are steroid failures. That number tends to be quite consistent in ASC. And we had 71% of steroid responders. Those steroid responders, 14% steroid dependent, 2% colectomy, 7% infliximab and treated well, 4% infliximab and then colectomy. These are small numbers. Some lost to follow-up. But again, we had 71% steroid responders, and then they went on down here. But let's look at the steroid failures. We had 33 or 26% on infliximab, 3 went to colectomy, and only 1 patient was started on cyclosporin. That 1 patient was well at a year. But what can you know from 1 patient? It's hard to know. But let's look at the 33 or 26% on infliximab. 76% responded, remained well, 52% remained well, 12% steroid dependent, 28% got colectomy, and 8% were lost to follow-up. The cumulative rates the cumulative rates of colectomy at 1 year, 37% infliximab cyclosporin, 19% colectomy, no second-line therapy for 59%. So irrespective of what therapy you choose, there is a significant risk of this patient ultimately going on colectomy following an episode of acute severe colitis. This is just an interesting slide I wanted you to look at because it talks about or shows you where is the site of action of all of these drugs. Here we have the anti-TNFs. Down here is the anti-integrin, vedolizumab. Remember, vedolizumab is the child of natalizumab. Natalizumab, we had the problem of the Jakob-Creutzfeldt disease. Never has that been reported with vedolizumab. Remember that natalizumab had the problem because of crossing the blood-brain barrier. But vedolizumab has never been associated with Jakob-Creutzfeldt. And here is the drug that Dr. Levine alluded to before, tofacitinib. Tofacitinib is a JAK-STAT kinase inhibitor. What is that? Well, the JAK-STAT signaling pathway is shown here. And so many cytokines involved in the pathogenesis of IBD signal the synthesis of inflammatory cytokines via the JAK-STAT pathway. This cytokine signaling induces phosphorylation of the JAKs, which phosphorylates STAT, and then these STAT proteins migrate into the nucleus where they activate the transcription of inflammatory cytokines. So by using JAK inhibitors, you prevent this cascade of events which will lead to the transcription, production, and circulation of these potent inflammatory cytokines. Tofacitinib is a small molecule that's taken orally. It is a JAK kinase inhibitor. It's approved for rheumatoid arthritis that has not responded to methotrexate. It's metabolized by the liver. It's approved by the FDA to treat UC in adults. It's currently in trials in children. And again, whether it's going to become a part of our armamentarium for ASC remains to be seen, but it appears to be quite effective in patients with mild to moderate disease.
Speaking from experience, I have used it in a couple of cases of ASC, and it is quite effective. We do have pediatric safety data, at least from, I think, Sinai. So I do think it's going to become part of the second-line therapy choices for ASC in the next few years.
I tend to agree with you, but I'm hedging my bets until we get more
and
definitive
it can be
studies.
hard to get approved just because, especially for younger children, because it's still only approved in adults.
On the other hand, as a maintenance drug, I've had no problem in the past getting vedolizumab approved.
Same.
So, toxic megacolon. Dr. Rabinowitz alluded to toxic megacolon. First and foremost, involves radiographic evidence of colonic dilatation. We saw the adult criteria to the left. Let's look at the pediatric criteria. That would be greater than 56 millimeters in diameter or greater than 40 millimeters for those patients less than 10 years of age, plus evidence of systemic toxicity, which are shown here, and include fever, tachycardia, dehydration, electrolyte disturbances, altered level of consciousness, or hypotension or shock. Not all of them, any of them. Abdominal radiography is used to screen for complications such as TMC and perforation. Remember that steroids can mask systemic toxicity and mask peritoneal signs. So getting an abdominal x-ray should be ordered on very low clinical suspicion. And again, I showed you what the colonic diameter is in the diagnostic protocol. The mainstay of treatment in TMC, these patients are NPO, these patients get IV antibiotics, correct their electrolyte imbalance, prepare them for surgery. Rectal decompression using a soft red rubber catheter along with positional changes has long been practiced, but there's limited objective evidence of benefit. And towards the end, when we get over it, I'd like I'd like to ask Dr. Levine about this because I always used it just like I use it for Hirschsprung's enterocolitis. I don't know whether it works or not, but it sometimes makes the patient feel better.
I haven't used it in ASC. The surgery team generally only use it for enterocolitis for Hirschsprung's in Seattle, so I have not seen it done for ASC. I can't comment, sorry.
There is a case report of successful use of infliximab for toxic megacolon, but there's a high potential associated risk involved. Again, this is not something we see a lot of, but these patients are certainly are, when they present, that's usually presented these patients tend to not be in the hospital for 2 weeks before they develop a megacolon. It tends to be a really rapid progression from their ASC to TMC. Although there's a high mortality rate in children, in adults, in children, there's no significant evidence of TMC being associated with mortality, although 70% required colectomy by discharge. Again, the others generally responded to steroids, at least initially. The predictors of surgical complications in children, in one retrospective study, patients who are given preoperative steroids, patients with a hemoglobin of less than 10, and again, here we are again with an albumin less than 3. A low albumin level, we've seen it as a predictor of infliximab. We've also seen it as a predictor of morbidity. A low albumin level is a marker also for increased risk of postoperative infections. Early decision-making should be made in these patients before inflammation severity further reduces albumin synthesis and increases albumin loss. Delay in surgical intervention to enhance nutrition is not recommended. I had one case who ended up, because of a surgical preference, went to another institution that I strongly recommended for surgery immediately. They decided to delay surgery in favor of more intensive nutritional management. All that did was delayed surgery by a month. It did not change the ultimate need for a colectomy. When one uses preoperative steroids, it increases the risk of anastomotic leak and infection, but surgery should not be delayed to taper steroid treatment. Azathioprine does not seem to increase a postoperative complication rate. Infliximab given before colectomy does not increase the risk of post-op complications. And one thing that does increase postoperative complications is sequential treatment of infliximab and cyclosporin. They should not be used in the same time period. That's not recommended for ASC or for TMC. The clinical predictors of surgery in children with UC, if we look at the pediatric IBD database, the North American Registry was established in 2000. We have 406 UC patients, 14% underwent surgery, and the median time to surgery was 3 years after the initial diagnosis. Now remember, this came out in 2012, so it was before infliximab was used more widely. I would think that that data would be even more impressive now with less patients undergoing surgery. If we look at overall colectomy rates, what are the significant clinical predictors? This is a 2-year on the in the middle and an overall on the right colectomy rate. Again, a very important determinant here is albumin. If the albumin is less than 3.5 overall, 24% of patients underwent colectomy. If they had a family history of UC, and I'm wondering why that is the case, I don't know. They also had a higher rate of having an overall colectomy. A weight loss at diagnosis, 28% overall colectomy rate. Cyclosporin, 52% colectomy rate, and tacrolimus, 55% colectomy rate if they were on either of those drugs. So how do we manage these patients? Just to review, this is a child with less than 18 years of age with ASC. Going to do a clinical assessment. We're going to admit for IV methylprednisolone. Withhold 5-ASA, strongly consider an abdominal x-ray, think about nutrition, and remember enteral is always better. If toxicity or colonic dilatation, NPO, steroids, antibiotics, and surgical consult. If infection is suspected, proceeding to surgery, use antibiotics. But in the absence of these two situations, if the PUCI is less than 45, continue corticosteroids on day 3. Consider oral steroids when the PUCI is less than 35. On day 3, if the PUCI is greater than 45, screen for second-line therapy, check all baseline investigations, involve the surgeons if not previously consulted, repeat your bloods. Sigmoidoscopy. If CMV positive, consult IDs for therapy. Okay, only if positive. Sigmoidoscopy, day 5, PUCI is less than 35, then we're back to continuing steroids and going to oral. 35 to 65, continue steroids for 2 to 5 additional days and re-enter the algorithm depending on the PUCI score. PUCI is greater than 65, start second-line therapy. In our center, it would be, I would think, almost exclusively infliximab, or go to colectomy. And that may be based on your history with the patient preference, etc. Day 6 and onwards, continue treatment and monitor progress daily. Strongly consider colectomy with any significant deterioration. Remember, colectomy is curative in these patients. And in some cases, it may be the preferred method of treatment. So to summarize, ASC is a medical emergency with a high rate of clinical deterioration and colectomy. Admission is required to manage severe systemic impairment, to evaluate for bowel dilatation, especially to evaluate abdominal pain that may be unrelated to having bowel movements, patients with marked anemia or hypoalbuminemia who are at increased risk. And remember that PUCI remains a the most important validated scoring tool in children. The first line of therapy is IV steroids, up to 60 milligrams a day. Stool cultures for enteric pathogens and C. diff. Again, when they present, get plain and upright abdominal films as a baseline for bowel dilatation. Remember, we're looking at the transverse colon as our signpost for TMC. Remember that cyclosporin or tacrolimus, if chosen to use, is given as a bridge to alternate maintenance therapy and stopped as the new therapy becomes active. The sequential use of calcineurin inhibitors and infliximab is discouraged because of toxicity, the increased infectious complications, and an increase in surgical morbidity and mortality. There's no strict criteria to define the failure of second-line therapy. Remember, we continue cyclosporin for at least a week and then reevaluate the PUCI. For infliximab or tacrolimus, which is somewhat slower than cyclosporin, up to 2 weeks. Infliximab may be continued as long-term maintenance therapy, and that, of course, is the most important thing to note, that while tacrolimus and cyclosporin are very effective in the management of ASC acutely, they are not long-term therapies. So we want to identify young patients with UC at risk of adverse outcomes early in the course of the disease. The younger the age, the higher the likelihood of presenting with ASC, and of course, our laboratory data. We want to select the best candidates for the early introduction of disease-modifying therapies, because the disease-modifying therapies, such as infliximab, are those that are associated with mucosal healing. And that is it. So we can stop the recording, and then I can